World Federation of Anesthesia tutorial and BJ article, right?
Yes, sir.
So regulation of magnesium balance is what we have to talk first. And in the whole body, magnesium is the fourth most cation after sodium, potassium, and calcium. And intracellularly, this is the second most common cation. Cation means positively charged ions. And the normal serum level is 0.7 to 1 millimoles. I don't think it is milli-equivalent, it is millimoles per liter. Whereas in milligrams, it is only 1.7 to 2.2 milligram per deciliter. Because it is mostly intracellular, the serum levels are very, very low. Of the total body magnesium, about half can be bound in muscle and soft tissue, the remainder mainly in the bone, small amount in RBCs also it is present. Around 1% of magnesium in the ECF is both ionized and ionized forms, the former being the physiologically active. So any ion to be active, it has to be in an ionized form. So no wonder this also has got both ionized and unionized forms. But unlike calcium, which is bound to albumin, magnesium is not directly bound to albumin. So approximately 1/3 of the dietary magnesium is absorbed, majority in the small intestine via a passive and transport system with a small amount in the large intestine. So there are two locations from which it is absorbed. One is in the small intestine, another in the large intestine also. The average daily magnesium intake is about 15 millimoles, and the changes in dietary intake or excessive losses are balanced by the kidneys. So what are all the three, just like what we saw in the calcium last week, the three important systems, the gastrointestinal system, the bone and the kidney. These are the three systems which balance and keep the levels in the required levels. So most of the magnesium appears in the glomerular filtrate, is reabsorbed in the ascending limb of loop of Henle, with only 1% being excreted in the urine. And parathyroid hormone enhances the absorption in the gut, just like your calcium. The parathyroid also helps in absorption of magnesium also, and reabsorption from the ascending loop of Henle, where it is, and also from distal tubule to maintain plasma concentration. Aldosterone increases the renal excretion of magnesium. So in hyperaldosteronism, you will find there will be a low magnesium level. As majority of magnesium is intracellular, chronic magnesium deficiency will result in depletion of body stores, but the plasma concentration may be relatively normal, which will be very, very misleading. You may be thinking it is normal, but the total magnesium may be low. A low plasma level, if it has become lesser than the normal value, that indicates there is a definite reduction in the total body magnesium. So this is more valid when there is a reduction in the serum level of magnesium. It indicates a definitive decrease, but a normal value does not confirm that the total potassium should be normal. It may be little low also, but that means it is a chronic affair. And what is the role of magnesium in the body? Magnesium plays an important role in establishing the electrical potential across all the cell membranes, as it is involvement of the sodium potassium ACPH system, which is responsible for maintaining sodium potassium gradients. So this gradient is indirectly managed only by the potassium level across the cell. And the biosynthesis of DNA and RNA, protein synthesis and production and function of ATP are all dependent on magnesium. And magnesium also affects calcium metabolism. So it is, both are very tightly interrelated. The production of cyclic AMP is magnesium dependent, which in turn controls the release of parathyroid hormone. So that is the indirect way it is controlling that. Therefore, deficiency of magnesium is often associated with hypocalcemia. So hypomagnesemia will be invariably associated with hypocalcemia also. Intracellular magnesium inhibits calcium influx through calcium channels, which appears to mediate many of its effects. As a result of this action, magnesium is often called the physiological antagonist to calcium. And the calcium is the physiological antagonist to magnesium also. So whenever you have high magnesium, calcium will correct it. When you have high calcium, magnesium will correct it. So both are interdependent. And the actions of magnesium on specific systems, on the cardiovascular system, there is a direct depressant effect on myocardial and vascular smooth muscles. Inhibits the release of catecholamines from adrenal medulla, peripheral adrenergic terminals, directly blocks catecholamine receptors. So this action is mainly utilized in pheochromocytoma patients intraoperatively also. As a result, cardiac output and vascular tone is reduced, resulting in hypotension and decreased pulmonary vascular resistance. And its antiarrhythmic effect, that is, earlier we saw it is mainly for membrane stabilization, maintaining the gradient of sodium to potassium. So in that way, it also helps to correct the arrhythmic property of the SA node, prolongs SA conduction, PR interval, and the AV node refractory period. So it is able to act as an antiarrhythmic agent. Coming to the nervous system, it reduces the release of acetylcholine at the NMDA, antagonizing calcium entry into the presynaptic. So release of acetylcholine is blocked, and the causes reduced excitability, and it has an anticonvulsant property. But this anticonvulsant, can you use it as for regular epilepsy? It has not been found to be very useful in idiopathic epilepsy or secondary epilepsy. So the convulsions produced in eclampsia alone, they respond as an anticonvulsant. That is why it is not used as a anticonvulsant for regular treatment of any epileptic patient. And it reverses the cerebral vasospasm. And coming to the musculoskeletal, it is involved in relaxation of the skeletal muscles, and with excessive plasma concentration causes muscle weakness also. Respiratory system, it's a good bronchodilator. It can be used even in status asthmaticus also as a part of the treatment if it is not responding to the regular bronchodilators. And but respiratory failure may occur because of respiratory muscle weakness, which it can produce. Even though it can directly dilate the bronchial tree, it is not. It can larger doses may cause muscle weakness, thereby affecting the respiration. And genitourinary system, it's a powerful tocolytic, causing decrease in the uterine tone and contractility, and it has got mild diuretic properties. Physiological platelet activity is reduced, resulting in prolonged bleeding time. And coming to the disorders of magnesium concentration, the first we will see hypomagnesemia, defined when there is a serum concentration of less than 0.7 millimoles, and frequently affects seen in malnourished and critically ill patients. So majority of the critically ill patients, if they are not recovering from their illness, you have to correct the magnesium level to make them mobilize or get more strength to walk and get up. And primary nutritional deficiency is uncommon in infants, even less common in adults, unless poor intake is accompanied by prolonged diarrhea or excessive urinary loss. And susceptibility to hypomagnesemia increases when demands for magnesium increase during critical illness. That is why in one of the discussions heard in the last week, nutrition in critically ill, magnesium plays a very important role, and it is essential for catch-up growth following recovery from protein energy malnutrition. And what are the causes? It can be due to decreased intake, the form of inappropriate IV fluid or nutritional therapy, malabsorption, dietary deficiency, can cause because of increased loss due to diuretics, nephrotoxic drugs, alcohol abuse, diarrhea, excessive nasogastric drainage, and genetic renal diseases like Whitman syndrome, And redistribution, massive transfusion of separated blood. It not only decreases calcium but also decreases magnesium, and insulin administration and hyperparathyroidism. These are all the causes for hypomagnesemia. Clinical features will be early consequences, predominantly neurological or neuromuscular abnormality, with the influence because of the potassium flux within the tissues. Anorexia, nausea, muscle weakness, cramps, lethargy, and weight loss are early symptoms. Later, patient becomes irritable, hyperexcitability, muscle spasm, stridor, tetany, just like hypocalcemia. All the features also resemble that, and then ultimately convulsions can happen. Hypertension is common, and pulmonary edema can happen. ECG may show a prolonged PR and the QT intervals, ST depression, and flattening of T waves. And supraventricular and ventricular tachycardia also may occur. So this is how this is hypermagnesemia. Normally seen in impending tetany as a result of hypocalcemia. The same hypocalcemic features like Progesterone and Jockstrap also may be seen in hypomagnesemia, and associated with hypokalemia due to urinary potassium loss and hypocalcemia due to reduced PTH secretion and end-organ refusals can happen. And magnesium depletion decreases both intra and extracellular potassium. So tissue repletion of potassium is virtually impossible unless hypomagnesemia is corrected. So this is a very important fact that we have to remember, that if there is an alteration in potassium balance and a potassium hypomagnesemia is present, without correcting the magnesium, it is impossible to correct the potassium level. How do you manage that? Treatment depends on severity and clinical status. Normal homeostasis of magnesium requires 10 to 20 millimole per day. Replacement is guided by serum magnesium levels. Also, it is mainly intracellular, so the serum levels may be a poor reflection of adequacy of treatment, but we must watch for the clinical improvement. And although magnesium can be given orally, this route is not very popular because it can cause diarrhea when you give it in large amounts, and intramuscular injections are painful. Even though one regime in my administration of magnesium for preeclampsia is the intramuscular regime, Richard's the regimen, and therefore IV route is most widely used. Magnesium sulfate comes as a 50% solution, which is 500 milligram per ml, each ml containing 2 millimole of magnesium. And severe or symptomatic deficiency may be treated by diluting 2 grams in 50 ml of 5% dextrose and giving it over 30 minutes. That is the mode of administration. Chronic deficiency can be corrected with larger amounts. That is, you can give 40 to 80 millimole IV over 24 hours, then switch it to oral intake. So this is how the presentation comes in 50% per ml, 2 ml ampules. So one ampule contains almost 1000 milligrams, which is 1 gram. Okay. So if you want to give 2 grams, you have to take 2 ampules. If you want to give 4 grams, you have to take 4 ampules. So that is the practical application of the presentation. Coming to hypermagnesemia, magnesium from the diet is relatively innocuous, as real elimination of excess magnesium is rapid. So even if you take too much of magnesium in your diet, it will be eliminated with the kidney function is normal. Antacids and purgatives often contain magnesium, and excessive intake can precipitate hypermagnesemia. So contamination of water supply has been reported also to cause hypermagnesemia. The most common cause is iatrogenic as a result of inadvertent overdosage by intravenous route, especially if the patient has a coexisting renal failure. Without knowing that, if you give the normal dose, it will result in hypermagnesemia. Rare causes include diabetic ketoacidosis and tumor lysis syndrome. In this condition also, patient may have Just like hypercalcemia, you can have hypermagnesemia also. The clinical features include frequency and severity is dependent on the serum concentration again. Initial clinical presentation may be headache, nausea, vomiting, diarrhea, hypotonia, and muscle weakness. And significant neuromuscular block can occur, causing respiratory muscle weakness and ultimately respiratory arrest. Hypotension and bradycardia occur at high plasma concentration. The ECG may show prolonged PR interval and QT, widening of Cura's complex, progress of severe arrhythmias, and finally cardiac arrest. So the earlier picture come here. By mistake, it has gone there. And these are all the various serum levels at which 4 to 5 muscle weakness, which is tested by patellar reflex. 5 to 7.5 respiratory weakness and respiratory arrest. 10 to 12.5 millimoles cardiac arrest. So starting from 4 to 12, remember in between starting with the muscle weakness, respiratory arrest, and cardiac arrest. The management is by prevention. You have to anticipate and prevent infusing large amounts. Patients receiving parenteral magnesium should be frequently monitored, and patients with renal failure should not receive magnesium containing medication without proper observation and follow-up. If renal function is normal, cessation of therapy often relieves the whole problem and levels come back to normal. If at all, you can give some fluid therapy and diuretics, just as we did it for calcium hypercalcemia, where we gave saline and diuretics. Same thing can be followed here also. Hemodialysis or filtration may be required in renal failure patient or in the presence of severe systemic effects. And IV calcium gluconate 2.5 to 5 millimole can be given again to antagonize the magnesium in cases of emergency or immediate management, followed by a diuresis with a diuretic. And these are all the various important things with regard to anesthesia. In anesthetizing hypomagnesemic patients, that may result in arrhythmias. So if the levels are low, you have to correct them before you take them up for surgery. The vasodilatory and myocardial depressant effects of anesthetic induction agents also precipitate hypotension in these patients. And magnesium sulfate therapy should be avoided in patients with atrioventricular block because it can result in asystole or worsening arrhythmias. Magnesium is effective at abolishing tachyarrhythmias and recommended treatment for tocilizumab and digoxin-induced and ventricular arrhythmias, which are unresponsive to other treatment. And a bolus of magnesium of 2 grams over 10 minutes is the dosage that you have to give for this. In shock, some cases of hemodynamic shock also, refractory to ventricular fibrillation, a 2-gram bolus of IV is given because magnesium does not interfere with the inotropic action of adrenaline. And magnesium can be used during surgery for pheochromocytoma due to its calcium channel blocking properties and suppression of catecholamine release. An initial bolus of 40 to 60 followed by 2 grams per hour has been suggested as a regimen for that. Magnesium and calcium channel blocking drugs can cause exaggerated hypotensive effect due to their dual effect on calcium channel. So you must exercise caution in using these two drugs together. There has also been released increased neuromuscular side effects and increased magnesium levels. The nervous system in preeclampsia and eclampsia, it has been reported that convulsions as a result of cerebral spasm, which is reduced by, which causes a reduction in blood flow, and this is reversed by magnesium. So magnesium causes a cerebral vasodilatation and increases the blood flow. So, and also it prevents the entry of calcium, which are the two mechanisms by which convulsions are prevented. And magnesium sulfate is a drug of choice for prevention of eclamptic seizures. But Progression to eclampsia from preeclampsia has been shown to be significantly lower when treated with magnesium as a prophylactic measure and trend towards lower maternal mortality. Dosage regimen, because there are various regimens that are used, but IV, you can go for a loading dose of 2 to 4 or 4 to 6 in the Western textbooks and maintain at 1 to 3 hours generally used. And a therapeutic range of 2 to 3.5 millimole has been recommended. Timing for discontinuation is arbitrary, but magnesium sulfate therapy is usually continued for 24 to 48 hours postpartum also in patients with preeclampsia, and so that you don't land up with a postpartum eclampsia. And magnesium sulfate is used to suppress the pressor response to laryngoscopy and intubation in pre-eclamptic patients, and surges in blood pressure can be perilous. A dose of 40 milligram is given immediately followed by the induction drug, and 30 milligram per kg in women already who have been put on magnesium sulfate as an infusion, you reduce it to 30 milligram. Otherwise, if it is the first time administration, you can give 40 mg per kg. Tetanus. Magnesium reduces spasm and an autonomic instability in tetanus. However, there are reports of hypotension and bradycardia and hypocalcemia and respiratory muscle paralysis requiring ventilation as a result of magnesium therapy. A proposed regimen for treatment of tetanus is 5 gram IV over 20 minutes followed by 2 gram IV, but keep a watch on all these developments, both on the cardiovascular and respiratory system. But this can be increased to 0.5 gram per hour until there is relief of spasm or loss of patellar reflex. Because of its muscle relaxant property, it is used in tetanus. If continuous infusion is not available, 2.5 gram IV every 2 hours can be given and frequency adjusted according to the system. And magnesium offers some analgesic activity also. A reduction in conventional analgesic requirements has been demonstrated when magnesium is given in the perioperative period. So this has formed one component of opioid-free analgesia. So nowadays this is recommended along with other drugs as a component for opioid-free analgesia. Magnesium also has a role in chronic and neuropathic pain, but it is still in the experimental stage. Magnesium potentiates all ND blockers, so you have to be careful. You must use a neuromuscular monitoring whenever a patient who has already had a magnesium infusion coming for surgery when you are using ND blockers. Due to the effects of neuromuscular junction, magnesium therapy may cause severe weakness in patients with diseases like myasthenia gravis or muscular dystrophy. So you have to exercise more caution in that. The respiratory system, as a result of smooth muscle relaxation, magnesium dilates both bronchi and pulmonary vasculature, and therapy appears to improve the peak PEFR rates with acute patients with acute severe asthma, particularly in children. And it should be considered in refractory cases of impending respiratory failure that is due to bronchial obstruction. It is used in cardiopulmonary bypass also, particularly common following CPB. There is a hypomagnesemia is more common, so to correct that also you can use to prevent morbidity. Other ischemic events that occur during critical illness often result in depletion of cellular magnesium. So the magnesium is widely advocated in the treatment and prophylaxis arrhythmias, particularly after cardiopulmonary bypass. And the calcium channel blockers, the patient may be treated both magnesium and nifedipine in pregnancy, which is complicated by pregnancy-induced hypertension. Since both exert an effect on calcium channels, interaction between these two agents may occur. So an increased hypotensive effect has been observed in these patients who have received both nifedipine and magnesium. So perhaps more concern is that nifedipine may potentiate the NMDA blockade, the toxic effects of magnesium also. So in practice, significant clinical effects are luckily relatively uncommon, but caution should be exercised when you have a patient who has been prescribed both and who has taken both. Okay, so that ends the presentation.